working. I don't know.
It is good. It's great. We can see you. Go ahead.
Perfect. So today we're meeting to hear from our esteemed panelists, Ahmed Faraz Khalid, Eric Seguja, Mylene Shung King, as well as Annie Maria Pulka Brandstrom and Brian Hutchinson, on using evidence intersectorally with experience from non-communicable disease and other current issues. I will be your moderator for today. My name is Nasreen Jassani, and let me see if I can, there we go. I'm based at the Center for Evidence-Based Healthcare at Stellenbosch University in South Africa. I'm also faculty at the Johns Hopkins University, the Bloomberg School of Health in Baltimore, USA, and the outgoing co-vice chair of the Evidence to Action Thematic Working Group for Health Systems Global. So I won't read anything of my bio, because what's interesting for today is our esteemed panelists. So I'm going to go straight to a little bit about the information and background for the session for today. Just a little bit of a review for those of you who might be new to the session. You can access the support chat function on the top right corner of the page at any time if you face technical issues. There will be a Q&A session after the presentations. So please send your questions in the live Q&A session. We'll be playing having each of our presenters speak one after the other. And all the questions and answers will be welcome at the end. But if you think of anything, please do drop it into the Q&A. We also have a discussion forum and would love to hear who's joining us today. So please introduce yourselves. And for the best user experience, we're being suggested that to view the sessions in full screen. Note that these sessions are available to view the next day, and they'll be available for the next 14 days, and so they're recorded. And do please adjust your screen as necessary. So our first speaker today is Ahmed Faraz Khalid, who is a senior research and learning consultant at the Canadian Red Cross. He's a medical doctor, a health policy researcher, and a lecturer on health systems and policy. His presentation today is going to be on the governmental health policy development process for Syrian refugees, embedded qualitative case studies in Lebanon and Ontario. Over to you, Faraz.
Hi, everybody.
Hi, everybody. My name is Ahmed Faraz Khalid, and I'm a health policy researcher. Excited to be with you all today to present the work on the governmental health policy development process for Syrian refugees. This exciting research project that took over sort of for the past couple of years, we really wanted to look at the health policies that were developed for Syrian refugees in both Lebanon and Ontario. Was research evidence used to inform those policies? And if not, what factors really influenced the development of those policies? It's important that I start my presentation by trying to tell you what we mean by evidence-informed decision-making. So for us, it was important to clarify that evidence-informed decision-making is not simply a process of providing more research evidence. On the contrary, I argue that there are plenty of research evidence that does exist, but what is missing is trying to find ways to support that use of evidence in decision-making. And I often get asked, well, what do you mean by research evidence? And we saw that from our interviews. So we interviewed stakeholders both in Lebanon and Ontario. And most often what we saw from the interviews that was coming out was that people define research evidence differently. It depended on who you spoke to, or their academic background, or their experience, or their organizational structure. They defined research evidence differently. So it was very important early on that we sort of establish what we meant by research evidence. And for me, especially, the research evidence meant the output of research that's been conducted in a systematic way and reported in a transparent manner. Now, we distinguish this research evidence from other types of information. So data, ordinary knowledge, and stakeholder opinion is other types of information that are equally important in informing policies and decision-making, but they're different than research evidence. So the gap that my study was trying to fill was that we know very little about the factors that influence the use of evidence in policy development and humanitarian crisis. We actually know very little about how to support real-time research evidence to inform decision-making in crisis zones. So this study specifically was really trying to look at the factors that influence the use of evidence in the government health policy development processes for Syrian refugees in both Lebanon and Ontario. We did this by examining the political system and interviewing key stakeholders that were involved in the governmental policy development process for to address the health needs of Syrian refugees. And we did it by doing an embedded case study design. So we looked at 2 policy decisions that were developed to address the health needs of Syrian refugees. We examined and reviewed public domain literature that was available in the public domain. We reviewed policy and media documents, and we conducted semi-structured interviews with 18 key informants in both contexts to really come to an understanding of what were those factors that helped influence the policy development process for Syrian refugees. Now, what's really important in the study, or the findings of it, was that research evidence was actually not the main determining factor. And that was quite surprising to me after interviewing everybody, that actually research evidence was not the reason why these policies were developed, nor did they really play a big factor in informing those policies. On the contrary, what we found from our study that there were 4 broad factors that really helped to explain how those policies were developed. Some of them were, for example, no veto points. And by that I mean is that there was no opposition to the development of policies that address the health needs of Syrian refugees. There was an alignment between political parties in both contexts to the need to develop policies to address the Syrian refugees' health needs. And that actually is very important for policymakers to understand that when there is such an alignment, the process of developing health policies becomes much more easier to do. There was also engagement with key stakeholders. So within their own communities, whether in Lebanon, with the UN agencies and other humanitarian aid workers, organizations, or in Canada with the Canadian Red Cross that was in charge of sort of addressing the health needs, this engagement with the key societal factors really played a big factor in how those policies were shaped and informed. But also that both policies in both contexts really spoke the values of the countries of acceptance and offering refugees to people. And that really helped propel the policy forward. And finally, we saw this idea of external factors. So whether it was United Nations money that really sort of earmarked towards the development of those policies, or in Canada, we saw the image of Alan Kurdi, the child that drowned on the shores of Turkey, really propelled and galvanized the attention of the public, but also policymakers, and really pushed them to develop those policies in a very fast time span. In terms of contribution to this study, this is a really important study because it identified political factors that otherwise were not known on how the health policy development process for Syrian refugees was developed, that many other policymakers can actually learn from. So now, when we're trying to develop health policies for COVID, for example, COVID-19 response, we can look at this study and see that, what are some factors that can help us develop specific policies to address the pandemic. But methodologically too, I think this study is key because it was able to review multiple sources of data to allow this very deep examination into how the policy development process unfolded. And what comes out of it in terms of implications for policy, which I think is very important, that every research project really has some implications for any policy endeavors in the future, is that when we talk about the political, health, and international humanitarian aid system, there must be a need for a strategic direction that comes from senior leadership level that would mandate that research evidence is explicitly considered in decision making, so that whenever there's an output, whenever there's a policy being developed at a ministry level, there has to be a very mandated strategic direction that says research evidence was used and explicitly used to inform that policy. And that will ensure that we're using the resources that are available to us at best capacity, and that we're actually improving the effectiveness of the intervention. Because what research evidence does is that it proves to us, or it informs us about what is the best practice in the case that we're trying to develop for. And in the health research system, there is really a need for stated strategic direction that would mandate that research initiatives support evidence-informed decision-making, so that researchers are working with policymakers so that their research projects are helping to inform any policies that come out from a government level. And finally, I just want to note that this work is really part of a big comprehensive project of research that has been published, and I'm happy to share any of it. And all of it is really looking at how do we support evidence use in crisis zones. And given today's climate with COVID-19, there's no better time to really keep reinforcing and trying to figure out better ways that we could support evidence-informed decision-making, especially in crises that we know are increasing over time. I want to thank you all for paying attention to this presentation, and I'm happy to answer any questions you might have. I can be reached on Twitter. I can be reached via email. And thank you for everybody who agreed to be part of the study, both in Lebanon and Ontario. Thanks, everybody.
Thank you. Thank you so much for us. Really fascinating in terms of the importance of KT tools in crisis zones, but also how to enhance evidence-informed decision-making, both from the research perspective, but also from the policy perspective, and how they can work well together. I'm sure there'll be many questions about that. Next, we have Eric Seguja, who's a research fellow at the Department of Health Policy, Planning and Management at the School of Public Health at Makerere University in Uganda. His key research interests are in health policy and systems management, and he's worked in a number of different areas, as you can see on the slide here. Eric is going to present to us about reimagining the national policy response towards responding to the growing burden of NCDs, and he's going to particularly focus on reflections from Uganda's policy priorities. Over to you, Eric. Thank you.
My name is Eric Seguja, and I'm presenting today on reimagining the national policy response towards the growing burden of NCDs, reflections from Uganda's policy priorities. This is what we undertook in 2009, and below is my background. We realized that there is a growing burden of NCDs in sub-Saharan Africa. These are mainly cardiovascular diseases, diabetes, cancer, and chronic respiratory illnesses. What is common among these is that they share a set of 4 risk factors, which is tobacco use, unhealthy diets, harmful alcohol consumption, and physical inactivity. Sub-Saharan Africa is disproportionately represented in terms of premature mortality due to these NCDs, and the WHO highlighted best buys to address the above-mentioned risk factors. Since 2015, they have been doing the progress monitoring to monitor the 10 progress indicators. In total, there are 18 policies aligned to the best buys among the 151 countries where the progress monitoring is done. However, there are variations in implementation. One key issue is that there is poor performance in sub-Saharan Africa. Even when you control for the socioeconomic development, you realize that sub-Saharan Africa performs relatively poor compared to other regions of the world. However, still there is scant information on the national level adaptation. The Ministry of Health in Uganda reimagined the health system response following these recommendations, and the aim of this study was to document the national level experiences. We undertook a qualitative cross-sectional case study where it was undertaken in the 4 regions, traditional regions of Uganda, covering 30 health facilities, starting from health centers to national level referral hospitals and other key players that are involved in the control and management of NCDs in the country. These were purposefully selected to give a regional representation, but also to get the actual implementation that is happening on the ground. We used the document review, in-depth interviews, and key informant interviews, and we followed the thematic content analysis using the policy analysis triangle. Now, the results I'm going to present here are those that are specifically focusing on the content. One of the key issues we realize is that the actions or the policy options that were undertaken at the national level reflect a multi-sectoral approach to national policy response in line with the recommendations highlighted by the WHO. These are basically in 3 policy areas. 1 is the legislation and the regulation, 2 is education, information, and 3 is in the area of physical policy. In terms of legislation, we realized that the first policy options that were taken were to control the harmful use of alcohol. The second was to control tobacco consumption. And in the areas of education and information, we see that a lot has been done in the areas of improving physical activity and control, sensitizing the masses about the harmful use of control and alcohol consumption. When we come to the physical arena, we realized that there were taxes that were levied, especially on tobacco, alcohol, and unhealthy diets, particularly the soft drinks. However, we also realized that there's been a slower progress for diet and physical activity compared to alcohol control and tobacco consumption. The earlier efforts that were also guided by the WHO were have seen the renewed action following the Global Action Plan on NCDs. The taxation objective, we realized that is not necessary for NCD control, but although there is a distal causality with which leads to NCD control, but rather we see that the incomes or the revenues that are realized from the taxation nationally have been dedicated to the fund that was put to fight HIV/AIDS in Uganda. In conclusion, I would say that the trigger of all of these policy actions that we are seeing specifically originated from the global campaigns, especially the action plan on NCDs. There are different stages of policy development with regards to the 4 risk factors that are predominantly leading to the rise in NCDs. Health-based interventions with the multi-sectoral approach were prioritized. There is legislation. We see that it's more about protection against harm and awareness creation. The taxation about increased revenue is more about increased revenue and not necessarily prevention and management of NCDs. There is political will and for physical activity and legislation, but less commitment. We see that most of the action plans have not been followed by concrete policy actions to ensure that physical activity is improved in the country. As I conclude, we realize that there are blood actions for out-of-school physical activity. Most of the interventions that are aimed at improving physical activity are targeting schools, and for the out-of-schools who are in some sections the main people at high risk, there is less that has been dedicated to this. Enforcement remains to be seen, especially in the long term at subnational level. In conclusion, I would say thank you.
Super. Thank you so much, Eric, and lots to learn from the experience in Uganda, and both in terms of from a multi-sectoral perspective, but also from a multi-pronged perspective. So now I'd like to introduce Mylene Shunking, who is going to be speaking to us about intersectoral policy evolution in the mitigation of NCDs, a policy analysis of global and regional diet and physical activity policies. Mylene is an associate professor of health policy and systems at the University of Cape Town in the School of Public Health and Family Medicine. And her key interests are child health and health leadership, and she's currently working with a research network called the Global Diet and Activity Research Network, and it focuses on researching diet and physical activity as mitigating factors in the fight against the NCD pandemic. Over to you, Mylene.
Good day, everyone. As a start, I would just like to acknowledge the entire team that I am representing here. Non-communicable diseases poses a significant and rising burden of disease globally, and in particular have grown in magnitude and impact in low and middle income countries in the past 2 decades. There are multiple determinants of NCDs, of which diet and physical activity are 2 key determinants. So in recognition of this growing impact on the burden of disease in MRC countries, a research network called the Global Diet and Activity Research Network, consisting of these 4 low and middle income countries, with a recent addition of Haiti, and the UK as the high income country in the network, had been established specifically to explore the kind of determinants that influence diet and physical activity, in these countries, and to provide us with policy-orientated lessons in order to create appropriate interventions at the different levels, country level, regional, global level, in partnership with policymakers, practitioners, and citizens. So one aspect of the focus of our work was to analyze policy at the different levels, at the global, regional, and country level. And this presentation focuses on the lessons that we've drawn so far from the global analysis of diet-related policies. So I'm going to skip the methodology, but as a brief overview, we've identified 63 global policies across different sectors, the health sector, agricultural sector, the food sector, and a few trade policies that we included in the analysis. We focus on policies that exclusively looked at diet, and in particular at the reduction of sugar and salt, as these two aspects had gained traction over the past few years. So we looked at policies between the period 2000 and 2019. And for these policies, we explored who the key actors were, what the specific policy proposals were, how the policy narrative had changed, and in particular, how it had changed around sugar and salt, how policies had considered adolescents, as that is the focus of the GIDA network work, and whether gender as a very important aspect had at all been considered. So when we looked at the key actors, it was clear that the dominant actors were the United Nations agencies across those different sectors I've mentioned. And in particular, we were interested to see how other actors had participated in this space. One particular actor, and that is that of the commercial private sector. And in a process that's driven by a particular actor in this global space called the Codex Alimentarius, we explored the role of the commercial private sector, and we've noted that they were a very present and a dominant force in policy debates, had quite often pushed back on policy proposals, and this therefore makes the presence of the big food industry as a powerful actor in both policy design and content a worrying but an unsurprising finding. So a few of the key findings that we have. Firstly, that there's been an escalation in NCD policy activities as we neared the SDG launch, that policy interventions in the global diet and country level space, it's complex, multifaceted, multi-leveled, which makes the policy environment very complex to negotiate and navigate in at a country level. There's a predominant focus on sugar reduction, but an emerging emphasis on salt, and a predominant focus in terms of interventions on marketing and labeling. So far in the policies, the focus on children and adolescents is quite limited, and it mainly centers around sugar reduction and mainly on marketing of sugar-sweetened beverages. And there's almost no gender lens. We've noted that the policies have shifted in its focus from individual behavior focused to recognizing the importance of structural determinants and intersectoral collaboration and responses. And in particular, it is important to note this as there's a limited influence that individuals have over the particular food choices that's presented to them. And these are very strongly driven by structural determinants that are embedded in the systems, both at the country level and societal level. So very importantly then, it's important that when interventions are posited, that it's not only requiring countries to develop responses, as countries often do not have the resources or the power to take on big multinational players such as the big food industry. There still is a high income orientation and dominance in policy proposals. For example, under marketing and labeling proposals, there's very little specific consideration of low and middle income country contexts, such as literacy levels, nutrition literacy levels, and informal economy contexts. Later policies, we've noted, though, are quite tentative and voluntary at a country level, unlike previously very dominant authoritarian approaches. And this has an upside and a downside, as tackling the multiple determinants of NCDs can't only be done in such a voluntary basis, but requires strong support of countries in a very structured and a systematic way across the globe. There's not enough time to go into all the challenges and opportunities that we've identified, but some of the key lessons for LMICs is that we can't underestimate the complexity of addressing policies and interventions in the NCD space. Importantly, country governments are unable to take a big food industry singularly, and so partnerships need to be forged, but it also does require a very concerted intervention at a global level to mitigate against the influence at country level. We require strong regional approaches, and there should be a balance between voluntary and mandatory country level responses. And very importantly, we'd like to advocate that health in all policies and youth and gender lenses in all health policies in relation to diet, physical activity, and NCDs in general needs to be adopted. Thank you.
What a fascinating presentation, Maylene. Thank you so much. And so many questions, I think, that'll come out of that in terms of the complexity you speak of. I was particularly interested in hearing about the gendered lens that was taken at the analysis, which I think is really interesting, as well as your comment about more awareness of salt versus sugar. I think something was trending on Twitter this week about Salt Awareness Week, and I wonder if that has something to do with it. Next up, we have Annie Maria Pulke-Brandstrom from Umeå University, who will speak to us about a decision support tool for social inclusion interventions, and whether cost-effectiveness thinking can be introduced into local government priority setting outside of healthcare. Her research focuses on the evaluation of the cost-effectiveness and equity effects of multi-sectoral, complex public health interventions globally and in Sweden. Welcome, Annie Maria.
In our project, we're developing a decision support tool for local government decision makers working in the area of social inclusion interventions. These are local government decision makers in Sweden who are working outside the healthcare sector. They've been locally elected to raise taxes in order to fund schools, social care, and they also have some public health responsibilities. Thus, this kind of local government decisions play a significant role in improving population health and well-being. However, when it comes to priority setting criteria, commonly the focus is on the potential for cost savings. And this is the wrong criteria from the point of view that it will not lead to efficient use of resources for maximizing population well-being. So in this project, we link with a parallel program of research developing a new outcome measure called Capability Adjusted Life Years that has the potential to help in exactly this kind of collective decision-making problems by capturing quality of life effects, including but not limited to health. It's a generic register-based tool, and the intervention being prioritized should aim to increase school completion or reduce high school dropouts or try to get so-called NEETs into education work and training. We don't provide any list of cost-effective interventions. Instead, we ask the user to describe the intervention, estimate intervention cost, and also intervention effect in terms of cases avoided. We have then built a life table model using register data and for the target group and comparator, with mortality risks based on education level and register data on, for example, incomes, taxes, and healthcare costs. The basis of my presentation are pilots that we've done with potential users in social work, public health, municipal public health, and social innovation offices. So a first result is that this kind of local government decision makers in Sweden really expect evidence of hard facts, short-term impact on one's own budget. And this is despite the fact that the main effect of social inclusion interventions is likely higher quantity and quality of life, but this is not seen as core information for decision making. So we try to repeat budget balance, yes, but it's only a means, not an end in itself. A second result is that consequences for others' budgets are perhaps surprisingly also interesting to potential users. So visualizing budget impacts, for example, for the national government, for an intervention mainly paid for by the municipality, is seen as potentially facilitating discussions about collaborative funding. And coming from public health or health economic analysis of public health interventions, a surprise has been that within social care, legal frameworks really limit the potential to use cost effectiveness as a criteria for priority setting. Traditionally, the focus has been on providing care and treatment, and an individual who's been subject of an investigation and has been granted assistance is legally entitled to receive care. Thus, assigning low priority to an intervention because it's not so cost effective is not really possible. And the fourth result is that interventions are rarely manualized. Rather, they're formulated individually to meet complex needs of individuals. And related to this, project evaluations, they typically describe outcomes for participants immediately after exiting the project. For example, how many or what proportion have been have taken up a job or are in some kind of study program. What we do in our tool is require users to think a bit differently, to think in a counterfactual way, and estimate the number of cases avoided. So in summary, what we're doing in this project is trying to introduce cost effectiveness thinking into local government priority setting so that they could have, with the help of this tool, an opportunity to better assess the value of interventions that prevent or reduce social exclusion. We use register data and show results with a lifetime perspective, budget consequences for each sector, but also from a societal perspective. And we show effects in terms of higher quantity and quality of life, capability adjusted life years. So this is a new way of thinking for many non-healthcare local government decision makers. And to facilitate use of the tool to change decisions, we are now running training sessions for those intended end users, but also local government politicians and bureaucrats using non-academic language and animated films, in addition to traditional workshops. Thank you.
Thank you, Annie Maria. Really fascinating and a nice introduction to an alternative way of thinking about cost effectiveness analysis. And it sets us up really nicely for our next presenter, who is Brian Hutchinson. He's a research public health analyst at RTI's International Center for Global Non-Communicable non-communicable diseases. And he's speaking also about cost effectiveness analyses, but thinking from more of an investment perspective. So his presentation is on the health and economic burden of tobacco use in 15 countries and the return on investment of tobacco control measures. Brian specializes in economic evaluations of health programs in low and middle income countries, and he performs a wide array of economic analyses, including cost minimization, return on investment, and cost benefit analyses. So we look forward to hearing from you, Brian. Over to you.
My name is Brian Hutchinson. I'm honored to be here to present the work of RTI and our partners, UNDP, WHO, PAHO, and the FCTC Secretariat. Over the last 2 years, together we conducted a series of investment cases for tobacco control in 15 countries. An investment case is designed to provide information to decision makers who are on the edge of making some kind of decision, in this case, whether to implement tobacco control measures. Each case begins by quantifying the total health and economic costs attributable to a given disease, or in this case, risk factor. Having described the extent of the problem, the cases then seek to identify actions to reduce the burden, analyzing the costs and benefits of implementing the interventions, and then finally lay out a roadmap forward that addresses potential funding gaps. Why do this for tobacco control? Non-communicable diseases represent a major portion of the global burden of disease, and yet they receive very low levels of funding compared to other diseases. On the x-axis of this figure, adding up all the NCD attributable future years of life lost and disease morbidity, you see that in low and middle income countries, NCDs account for about 1.3 billion disability adjusted life years annually. Yet adding up all the development assistance for health dedicated to NCDs, so that's donor funding from bilateral, multilateral, nonprofit institutions, NCDs only receive about 64 cents per dali, a much lower dollar per dali figure than other major diseases. Tobacco is one of the main risk factors for NCDs and is responsible for about 12% of all NCD dalis, and the arrow represents an opportunity. If the history of smoking in low and middle income countries could miraculously be erased, the disease burden would be reduced, saving lives and reducing health expenditures and other economic costs associated with smoking. We examined the extent of the tobacco attributable disease burden in 15 countries that were selected as part of the FCTC 2030 project, and then analyzed the extent to which, in specific national context, tobacco control measures can reduce the burden in each country. Smoking prevalence ranged between about 5% in Chad to 43% in Jordan, and altogether these countries had 41 million smokers who had an increased risk of morbidity and early mortality from diseases such as cancer, CVD, and respiratory illnesses. As signees of the FCTC, all countries in our analysis are obligated to implement tobacco control measures, including the demand reduction measures that you see shown on this slide. For each measure, the FCTC recommends specific levels of intensity. For instance, taxes are recommended to form at least 75% of the total price of tobacco products, and graphic warning labels must cover at least 50% of tobacco packaging. The table at right shows the implementation status of the 6 measures across the 15 countries. So countries were assigned a score of 1 through 4, with 1 representing having no measure in place and 4 representing having the measure in place at the intensity recommended by the FCTC, and 2 and 3 representing gradations of achievement between. For instance, no countries in the analysis mandated plain neutral color packaging of tobacco products, earning an average score of 1 across all countries, while many demonstrated higher levels of achievement in, say, banning smoking in public indoor spaces. Within the investment cases, we analyzed the impact of countries moving to full implementation of these measures. And to do so, we follow 5 steps. First, we draw on data from IHME's Global Burden of Disease database on tobacco attributable mortality and morbidity. And these estimates form each country's health baseline. Next, we quantify the extent to which ill health generates economic costs, including public health expenditures and worker-related productivity costs. So the value of lost productivity due to premature mortality, missed smoking-related causes, or reduced capacity to work due to ill health or increased smoking breaks compared to non-smoking workers. Estimates of each of these were derived from the literature. Next, we quantified the extent to which FCTC demand reduction measures can reduce smoking prevalence using impact estimates from David Levy's tobacco control scorecard, and the extent to which those changes reduce the economic costs of tobacco use were then derived. Finally, we estimated the cost of implementing and enforcing the policy using the WHO NCD costing tool and compared cost to benefits to assess the return on investment. Breaking down these losses, we found, following these steps, we found that the economic burden of tobacco use in 15 countries is enormous. Across all 15 countries, every year, tobacco use causes about a little less than 19 billion in annual economic losses across the 15 countries. Those losses range from representing the equivalent of 6% of GDP in Jordan, where nearly half of all people smoke, to less than 0.5% in Chad, where 5% of people smoke. Breaking down these losses, now we find that about 19% of all of the losses are comprised of health expenditures to treat smoking attributable disease. Most economic losses are indirect productivity losses flowing from those things that we talked about before: premature mortality, absenteeism, presenteeism. Examining the impact of implementing the FCTC interventions, we find that over the next 15 years, by implementing new measures or intensifying existing ones, countries could save nearly 1.2 million lives and reduce projected economic losses by over a fourth. So as the slide shows, if countries do nothing over the next 15 years, they face losses of 226 billion, while implementing the measures would save 60 billion in economic losses. We compared the cost of implementing the package of interventions in each country to the economic benefits that it provides, and found that on average over 15 years, every dollar invested in tobacco control measures provides $120 in economic benefits and returns on average across the countries. The tree diagram at right visualizes which individual measure provided the highest ROI, with taxes leading and advertising and graphic warning labels also grabbing a share. In summary, proven cost-effective measures can reduce the burden of tobacco use, meaning that in a landscape with little global funding, donor funding, there's an opportunity for even resource-constrained governments to put a dent in the NCD burden. To date, investment cases have been conducted in 15 countries. The cases have been leveraged by ministries of health and other actors to move implementation of the FCTC forward. The case results were used in Georgia as evidence to support implementation of a comprehensive tobacco control bill. They've been used in another country to inform a regulatory impact assessment in support of a new tobacco control law. And prime ministers in 2 countries have seized on results to advocate for tax increases and implement plain packaging. The investment cases have contributed to FCTC implementation. With that, I want to wrap up and just thank again the organizations that are listed on this page and the conference for the opportunity to present these findings. Thank you.
Thank you so much, Brian. And I think you've set us up nicely for one of the first questions that's come through. It's time now for the Q&A session. And I would like to request all our panelists to please put on their videos so we can see you all. And perhaps when questions are posed to you, whether you can then unmute yourself, respond, and then mute yourself again. We're going to go through one round of questions, see how long it takes us. If we have time, we'll go through another round. And if not, then we might do a couple of wrap-up questions that might cut across all of your issues. So I'm going to start with the first question for Brian. And what I'll do is I'll ask each of you the questions that have come through so you have time to prepare for them. And then if you can just respond in the order that I'm asking them. So Brian, the first question for you is, what are your reactions, if any, to the presentation by Annie Maria on capability-adjusted life years, as well as the moral or ethical need at times for cost-ineffective interventions, as important in order to avoid social exclusion? That first one will go to you, and while you're thinking about that one, Annie Maria, for you, similarly, how would you imagine the tool that you speak of being used for NCD interventions that have been described by members of this panel? Any of the other NCD interventions beyond the ones that you've spoken about? And would this, therefore, would this tool, can you imagine it working for tobacco or diet-related interventions as well? And I'm sure that'll be interesting for some of our other panelists. Maylene, the question for you is that we learn very much about the policy analysis of diet, but could you say a little bit more about the physical activity policies that you mentioned in the title of your presentation, and whether you noticed similar imbalances and challenges in the physical activity policies as you did with the diet policies, assuming that it affected different kinds of industries and actors? And then for Eric, it's not, the question for you is that it's not very clear what your actual policy responses in Uganda were for the 3 areas. It's very clear what the desired outcomes are, but what were the actual actions? Was there actual new legislation and regulation to control the harmful use of tobacco and alcohol? Were there fines? Was there labeling requirements? Were there advertising bans? What were the fiscal policies? If you could speak a little bit more about the policies that would have helped with the outcomes that you've mentioned. And then for us, the last question you have here is, you spoke about the importance of developing a KT tool for crisis situations, such as the ones that you spoke of in terms of the Syrian refugee crisis. Could you speak a bit more about the KT tool that you envision? And what else is envisioned in terms of its form as well as its utility in the field across different crises, as you mentioned, that would be so important. So that's the round of first questions that we have. So over to you, Brian, to kick us off, and then through to the rest of you in that order.
Thanks, Benjamin. So my question, just to review, was about my reaction to capability-adjusted life years and how someone might think of cost-ineffective interventions and what to do about those. And my reaction to the capability-adjusted life years is I think that it's a fascinating effort to place a value on things that we sometimes don't have a quick and easy answer for how much value they impart to society. And I do think that, you know, when we look across health, it has such a range of impacts. And we've seen this year with the COVID-19 pandemic, but, you know, health affects the economy, health affects our social lives, the way that we connect with others. It can have, through products that influence health, an impact on the environment. So I think that, you know, we don't often have quick and ready tools available to monetize some of those impacts, but that the effort to do so and to place a value on the range of consequences of ill health is a very valuable one. And it's something that we struggle with and try to do in our own work. The idea of a cost-ineffective intervention, you know, I think it's difficult, I think, because money sometimes has primacy in society, and again, in the way that we are able to sort of attach value to things. But the choosing to implement something that is cost ineffective is a societal choice, and it depends on sort of our own culture and the value attachments that we place on different things. So if an intervention is cost ineffective and a society chooses to implement it, I think it says something about their priorities, and that that's a choice and a reflection of value in its own way. So we have cost-effective measures, I think, to guide individuals and decision makers on where benefits lie, but sometimes there's other choices at play, and societies can make that choice as well.
Thanks, Brian. And I think it also raises some of the queries that come from funders on social returns on investment, in addition to just financial returns on investment and how we think about cost effectiveness. And I think it's a perfect setup, Annie Maria, for you to perhaps respond if you'd like to Brian, but also weave that into your response to the question that was posed to you.
Great, thanks. I can first say that what I learned about social work through this project is that kind of way of thinking on the ground in terms of deciding which interventions to give to an individual. It's really that this individual has a problem, we have to do something about it. So that's what we have realized, that this idea of, is the intervention going to work? Is the cost going to be worth it? It doesn't really enter into that practical decision making. But yeah, I think in tobacco, Brian, you are privileged to be able to work with an area where there's really a lot of evidence of what works. And so it's really striking the magnitude of the savings that can be achieved by just implementing what we already know would work. And I think the role of, or the place, since Nasreen, you asked me to try to imagine how our tool could be used in one of the other areas, and I will choose this tobacco area. And the place for the kind of tool we've developed would be really not on these national or governmental level policies, that was the focus of your presentation, Brian, but more on when those are already in place. There is still a lot to do on the level of municipalities, and I will talk about schools, about how to do this kind of classical public health work in terms of trying to prevent youngsters from taking that first smoke or starting to experiment with tobacco products. And there the challenge is for that principal in the school, that this will take, if they decide to invest the time in this kind of preventive work, it will take time from the school staff, and their main mandate is not to improve health, right? They're there to provide education for the children. And that's really where we try to come in with our tool, to kind of accept that your main focus here is not to improve health, but your work has implications for the health and well-being of the youngsters. And let's try to quantify, to relate, mainly it's about time cost, right? To relate the cost of the intervention, which falls on you, to the consequences for the youngsters and also for other sectors of society. So it's really when there's not so good evidence of what works, and the decision maker doesn't have this kind of ready list of interventions to choose from, that's where our kind of tool hopefully can add some value.
Super interesting. Thank you, Annie Maria. And Brian, I see you nodding. Did you want to respond or react before we move to Maylene? Okay, over to you, Maylene.
Thank you, Nasreen. So I just wanted to say that the physical activity policy analysis is still underway, so we haven't quite got into the detail of it yet. But I think some issues to highlight. So Brian, in his presentation, alluded to the hierarchy of global responses to different disease burdens and NCDs being quite low on the list. So similarly in the NCD space, there seemed to be a hierarchy of responses. So from our policy analysis, there's far fewer physical activity related policies that we found compared to diet, both at a global and at a regional level. And I think it would be similar at a country level. So that's the one thing. So physical activity seemed to be lower on the hierarchy of responses. And what we have considered in the physical activity policy space is that I think both spaces, diet and physical activity, are very complex, multi-leveled, multi-layered, as we said in the beginning of the presentation. But I think in the physical activity space, the imperatives that seem to drive NCDs, it's far less under the control of the health sector than the diet space. So even in the health sector, in the diet space, the structural and commercial determinants that influence dietary choices and dietary intake are significantly outside of the control of the health sector directly, but even more so with physical activity. So we had to look at spaces such as urban planning, transport, and in particular, where there has been work done on physical activity, there's been a strong emphasis on transport and the issue of motorized versus non-motorized transport. Safe spaces where safety and security is an issue, especially in dense urban settings, especially where there's peri-urban informal settlements, work and the nature of work. And then coming back to some of the issues that Anna-Marie raised, we are recognizing that the places of intervention is very much a settings-based approach. So schools, for example, as a setting where physical activity could be promoted quite strongly, and hopefully those I think behaviors extended into adult life. But again, I think in both instances, it's not about individual behavior choice only, as has been very strongly, I think the orientation of the earlier policies had been very strongly around changing individual behavior. Here, we simply have to engage with the upstream structural determinants, both for physical activity and diet. And if we don't do that, I think the little bit of effort that we can make in the health sector will not be enough. So I think we're looking forward to seeing what comes out of the physical activity policy analysis. But again, even though gender plays such a significant role in the nature of diet and dietary choices, as well as physical activity aspects, it's again glaringly missing in any of the policies, and the issues of children and adolescents in physical activity, again, not as strong as one would have imagined. But I did want to link it a little bit to Brian's presentation. So what we are finding is that the tobacco lessons from the tobacco policy space and the interventions in the tobacco space, and also the kind of structures, governance structures that's been created at a global level to address the tobacco interventions seem to be a space that we could learn from quite a lot for how to engage with the NCD, the other aspects of NCDs such as diet and physical activity. So I think the aspect there methodologically and otherwise of policy learning is a very important one, and it'd be interesting to chat to Brian at some point as to what can we learn from how tobacco control was affected that would be of relevance in the diet and the physical activity space, so that we don't repeat the mistakes from the past, but that we are able to build on some of the successes that have been achieved in the tobacco space. So I hope that kind of addresses the question, Azreen.
Super, thanks, Maylene. And I think you'd spoken a lot about power imbalances, and just wondering if you had anything to say about whether other NCD affected sectors we can learn from in terms of these kind of dealing with power imbalances, whether it's, you know, big pharma, alcohol industry that provide lessons for managing the power imbalances that you were speaking about.
So I think, yes, of course, there would be many, many lessons to learn. But I think the one thing that did strike us as we navigated the dietary policies is that the big food industry, which is obviously the power, the power imbalance that might come into play in the dietary space. The food and diet is a very, very complex entity. So I'm not trying to reduce tobacco to a simple entity, but I think engaging with tobacco as a single product is much perhaps a little easier than the complex range of products and the process from production through to retail and so on that you have to deal with in the food industry. So the number of players in the food as well as the physical activity area are I think multiple and many, many more, especially the players that we feel would have negative impacts on any kind of interventions. And so those players were the economic and commercial interests that would push back. So we are noting, I think, very strong power imbalances in some of the policy dialogue spaces, but it's difficult to elicit that completely just from a documentary review. But for example, there's been a huge pushback from the food industry players that sat at the table around labeling, for example, and as well as food additives, and having quite a strong influence at the World Trade Organization, where while we're advocating for health in all policies, including trade policies, the WHO had quite a weak influence in making sure that trade policies would be in favor of I think, more healthy dietary products and practices. So the power imbalances are significant in the global space. And I would imagine at a country level space, especially countries that are heavily dependent on certain food industries in their economies, it's very difficult for a small country, perhaps with weaker regulatory systems and so on, to take on the big food industry by itself. And therefore, I think in my presentation, I mentioned that some of these interventions should have to be set at a very high level. And I think we all understand how difficult that is because of certain dominant influences in those spaces. I won't name specific influences here, but yeah.
Understandable. Well, maybe that sets us up nicely to speak from a country level perspective with Eric and the questions that were posed to you on how this is working at a national level and the rollout of some of these policies that can be clarified. But an additional question has come in, Eric, in terms of the enforcement that you were speaking of at the subnational level. Are the issues of enforcement about the awareness of the policy, or is it about going against local incentives that currently benefit from non-enforcement? So over to you, and feel free to take the questions in any order that you prefer. If you could just unmute your mic. Perfect.
Thanks so much. There's quite a lot that has gone into the policy in terms of content. And in 2015, that's when finally the country was able to come up with a tobacco control policy, which is a comprehensive smoke-free legislation, and it has different contents in there. One of it is protection, especially of the non-smokers from the smoking environment. One aspect that is particularly addressed is guarding against smoking in public spaces. The legislation says that at least a smoker should be 50 meters away from any public space, and this includes hotels and any other public space. But also there is protection of children and young adults below the age of 21 years to ensure that they are not sold to, they are protected from buying cigarette and tobacco products. The other aspect is legislation on advertising, promotion, and sponsorship, especially from the manufacturers. Then there is an aspect of education and behavior change. Then there is an aspect of fiscal legislation where there is enforcement of fines, which is an equivalent of 60 USD in case one is found smoking in public spaces. But there's also income that is coming from sale of these tobacco products. Unfortunately, the revenues or the returns from that were committed to what's known as the HIV Trust Fund. Other than addressing the effects of smoking, it directly went into the HIV Trust Fund. Yeah, that's what I can say with regards to that question. And of course, there are challenges with the enforcement at subnational level. It's one thing to have policy provisions in terms of written documents and enforcement. There are many challenges with regards to enforcement, especially with regards to who should enforce these behavior changes or breaking against these laws. It's still a dicey aspect when it comes to enforcement. But otherwise, with regards to making policy provisions, many of the aspects that I've talked about are reflected in the policy documents, but enforcement is a different thing altogether. Thank you.
Great, thanks, Eric. We have about 8 minutes left in the session, so I want to make sure that Firas, you get a chance to respond, but maybe we might have time for one cross-cutting question before we have to wrap up, but let's see how we do for time. Don't want to rush you though, Firas, want to hear your answer.
No, I'm happy to make this very succinct and short and to share with anybody listening a more detailed answer at any point. I provided my email address and I can do it again. I just want to say thank you, Nasreen, for facilitating this incredible session, and for all the speakers. It's been a great opportunity to learn from each other. To answer your question quickly, I guess the big strategy that we're looking at, and it's part of a larger work that I've been devoted to for the past few years, is about figuring out what strategy would work to address evidence-informed decision-making in crisis zone. And the one thing that came out from all our interviews with major stakeholders and decision makers across the world is this idea of a rapid evidence response service. And by that, I mean, I think the one thing that's sort of missing from that idea is that it's not enough that decision makers who work in crisis zones want research evidence. It's actually they want it in parallel to personal experience, tacit knowledge, the documents and data review from the own organization. They want operation and research evidence data to go in together to inform a response. And that is, I think, the link that's missing. I've been working a lot with organizations who are devoted to crisis zones in the past 2 years to figure out how can we build that mechanism. And I think actually if we eventually able to nail that down, it can be very much translated into government level positions too, and organizations. Right now, we're wrapping up a study on figuring out evidence summaries and how decision makers like that template and format. There's been a lot of talk about their impact in decision making, especially in crisis zones, because people don't have the capacity, or decision makers don't have the capacity to really read systematic reviews, and they're looking for more a synthesized version of that. So I'll leave it at that to allow more cross-cutting question to happen. Thanks, Nasreen.
Thank you so much, Firas, and I think you've set us up for maybe the one cross-cutting question, and I invite all of you to respond to this. It's really about these tools. So we've heard about several tools in this panel, but as you said, for us, decision makers sometimes require multiple inputs to their decision making and multiple sources of evidence. But it's also possible that they will be presented with results from multiple kinds of tools. And if you were all presenting, and in the spirit of the fact that this is an HPSR conference, I'm going to focus on the policy side. If you were all presenting your tools to decision makers, how would you convince them of the value of each of these independently or together in the event that they felt that they had to choose a way of valuing the analyses that comes out of them? From everything you've heard from each other, are these tools compatible with each other, or do you see them being used in completely different situations? Over to the rest of you. Feel free to jump in. Anyone can go first.
Maybe I'll start since the mic is on me. One thing that what I found when talking to decision makers who work in crisis zones around the world is that to advocate for the use of a tool, whether it's a rapid response service, whether it's evidence summaries, is actually to start at the ground zero, which is to advocate why research evidence is important to inform that decisions. And one thing that we saw where it really matters is when it comes to money. And so when you come to them from the idea that, when you use research evidence, you'll have better, more effective interventions, more accountability for donor funds, you sort of are able to get the buy-in. But also more importantly, what I'm noticing from my work right now with the Canadian Red Cross is also that decision makers don't want to be burdened with extra use of a tool. So it's a very fine balance between researchers and analysts who work in this field to figure out what can we implement that doesn't allow a burden on the decision makers or policymakers.
That's great. Any reaction from others that have shared tools? Brian, Annie Maria, Maylene?
I can add to that I think it's on us as developing tools to find the right words and the right emphasis. In my case, I'm trying to sell cost effectiveness thinking, but I also have to know what they want to see up front. So that's why at the top of my tool, I give the short-term financial impact on you. And then I build on that. And we worked a lot on trying to use the right language. So just a simple word like intervention, we figured out through the pilots that translating that directly to Swedish has a very bad connotation to certain people. So then we say sometimes project, we use another word. So it's like our job to really find what are they interested in? What are they talking about? How do they describe their own problem? Otherwise, I'm giving a tool to solve some problem that I think they have, but it's not the right one. And I think mine today is very different from your the other presentations in that really the space we're filling or trying to fill is when there is really very little evidence about effectiveness, what works and how much it costs. But we think still even there as researchers, we can try to help give some ideas of what kind of questions to ask. And looking at this from others' perspectives and a longer term perspective.
Thank you.
That's what we can try to do.
Brian, quick 30 seconds. And then Maylene.
Okay. Yeah, I do think that there, hearing today from different speakers that there's a lot of opportunity to marry some of these tools and processes together. We heard from Maylene about the intensive stakeholder mapping that she did, and the wide range of actors and institutions, market forces that play a role in creating the status quo. And processes like those to really map that out and give policymakers perspective on the different stakeholders involved and where they can press to change something is a really important part of the policy process. And our partners, the UN Development Program, do that as part of investment cases as well, kind of an institutional context analysis that gives force to how things can be implemented. And then, putting that together with something like an economic analysis that then looks at, what are the different things that should be implemented based on a certain set of criteria, showing the pathway forward, saying, if this is going to cost you an extra 5% of government total health spending, how can you raise those funds? So then maybe marrying that with an analysis of what tax revenues through tobacco can generate and starting to chip away at what we know will be some of the roadblocks to implementation moving forward as well. So I think the farther we can go in that process, looking back at why things are the way they are and how we might be able to change them by influencing actors, setting space for what can happen if we change things, and then removing or analyzing the roadblocks for how that change can take place, moving along that whole spectrum, marrying some of these tools together, I think can.
Perfect. Sorry, I'll have to stop you to give Maylene a bit of a chance. We're on a 25-second countdown. Over to you, Maylene.
So I'm just going to say, Nazreen, that for me, tools are a means to an end. And so it's not so much about the tools. And for me, the most important tools that we can amass ourselves with when we try and engage with policymakers is to develop trust to build relationships and partnerships. And I think whatever emerges from our tools, to be honest about uncertainties that we have from our research evidence, and not try and oversell what we have. But I think that to have very clear messages that are honest, and where our assumptions are made very visible to policymakers. So for me, yeah, it's slightly less about the tools themselves than the processes into which we then take those tools and what we've learned from our analysis, and that's very dependent on trusting relationships, I think.
Absolutely, and it brings us back to the whole stakeholder engagement argument. But I want to say, unfortunately, we've run out of time. I want to thank all the panelists. Thank you so much for sharing your results with us, for making the time to engage in this really great discussion. And for those of you that are continuing to join us for the rest of the day, you can just press back on the timeline button and join other sessions later for today. Thank you, everybody.
Thank you.